Thank you.
We are live. Greetings, Cormac Convery up there in Glasgow. You are a aesthetics lead at Ever Clinic in Glasgow, and the man who's done this amazing job with rhinophyma for the lovely Alan, which has clearly changed his life. And we are talking today about rosacea and rhinophyma. So, where shall we start? Let's start with rosacea itself. What is it, and why does it seem to get worse with age?
Well, rosacea, particularly in Scotland, is an incredibly common condition. It's also something that's very underdiagnosed, we find, and I seem to, on a daily basis, tell people that they've obviously got rosacea, and they say, oh, I've been seeing my other healthcare provider for years and never been told that. It does seem to be much more common in Celtic skin. It is an inflammatory skin condition, and there are different subdivisions. Classically, we say there's 4 main types, although there are some rarer other types as well. Most of our patients will say that they've got redness. Some will say that they've got plukes or spots on their skin. And of course, as with many other conditions, it can wax and wane to an extent, although, as you alluded to, it typically does seem to get worse as we age. Lighter skin types are susceptible to sun damage, and that will tend to give these distended or dilated vessels on the face, and they will be permanently visible unless you treat them typically with a vascular laser. So we do tend to see it getting worse with age. Alan, who you'd mentioned, obviously has phymatous rosacea, or he has rhinophyma, and that's a very distressing condition where well, for rhinophyma particularly, it's the lower nose that becomes thickened and enlarged and disfigured, and the patient ends up feeling like they're some sort of monster, or they're not, certainly not publicly presentable. And we've had many patients who find that they just withdraw as a result. But yes, it's a common condition, or rosacea is a common condition that does manifest more outward towards the world as we age and mature.
Well, absolutely. I mean, especially women around menopause find that they get flare-ups. So do we know why it becomes worse? Is there a hormonal element to it, I guess?
Yes. And that's one of the interesting things, is that for the most part, rosacea is more common in females, although phymatous rosacea is more common in men. And there are all sorts of influences, although we don't fully understand exactly what's underlying rosacea, and there is an element of variability. The different types can overlap, so patients will quite often have possibly 2 or more types of rosacea at the same time. And yes, there can be factors. If I'm not sure if that's your police vehicle or my police vehicle.
You. This is the office overlooks a busy road.
Okay. Right. But obviously, as ladies mature and they enter the menopause or premenopause, then with that flushing, that will tend to exacerbate their underlying rosacea as well. There are many triggers for rosacea. Some of them are dietary, can be sunlight, can be just changes of environment. So this time of year, we're seeing people complaining more because they're going from warm to cold environments a lot. We don't really tend to get much sun in Glasgow at the best of times, so we don't tend to see much in the way of a summer flare-up with rosacea. But yeah, there's multiple factors. Even coffee can exacerbate as well.
You mentioned dietary a minute ago. I mean, people often say, spicy foods and things like that. But are there general sort of day-to-day dietary things that could make it worse?
I mean, it varies individual to individual, and people will sometimes, present, slightly odd symptoms in terms of what may trigger them. One of the underlying things that we associate with rosacea is that tendency towards flushing. And, if we look back to those of us who as teenagers were more likely to blush, for example, there is a correlation between having that tendency and then, as we mature, starting to get more rosacea type symptoms. that said, that would classically be linked to having light skin, or Celtic or Fitzpatrick 1 or 2 skin. But I've got patients who have Indian, from the Indian subcontinent, who have rosacea, although that is a much less common presentation than, for example, Celtic skin. That we know more.
Yeah, it's interesting because you mentioned there the flushing, and as you know, because I've told you and I put in the promo for this, my horrendous experience with the hospital when I went up there with a family history of half my family dropping dead from strokes, father paralysed on one side of the body for it, blood pressure through the roof, got in there, almost felt like I was going to pass out, had a panic attack, thinking, oh my God, this is it, I'm actually going to have a stroke, I'm going to die. Beetroot red, get wheeled around into the doctor's section, and was treated like an alcoholic for the whole night. Every single question was about alcohol consumption, and the only thing they gave me when I left was the script for the thiamine, and no advice on blood pressure whatsoever. So I understand the discrimination that people can face when because it is. I mean, I imagine that poor Alan with the nose as well, because that's what they used to call it, wasn't it? An alcoholic's nose.
Yes. Yeah, and that's just yet another element to the stigma that patients with that condition do experience. And for many years there was that link, and you must be a drinker. How much do you drink? How heavily do you drink? And that stigmatization is just another layer of challenge that patients don't need. And I feel so sorry for your own experience. I mean, you just don't need that when you're feeling unwell. And as healthcare providers, we're duty bound to avoid judging people. The challenge for patients, and like Alan, for example, is that you continually feel judged for choices that you haven't actually made. And we see a lot of rhinophyma, and the majority of our patients either don't drink or drink sensibly and proportionately. And it's just such a shame to be, misrepresented.
Absolutely. And the other thing that often gets confused with is acne as well, doesn't it? Because it can be quite a pustular condition.
Yeah.
And then getting the right treatment for it can be hard as well. Do you see that quite often, that people come in and they say, I've been doing everything for acne for years and nothing's worked?
Yeah. No, absolutely. And we do see patients who have both. And, that's just yet another one of the challenges. And of course, when you have multiple conditions, it's a case of trying to tease out what exactly you're dealing with at a given time. Recognizing that for a lot of patients, particularly with rosacea, and when you've got the papulopustular, or the one that you're alluding to, there's often barrier issues with your skin. So your skin being a very large organ, part of its function is to keep the outside out. And if you've got a sensitivity, which can make any topical treatments so much more challenging, then it can be soul destroying, because of course you try things and they make the skin worse, and patients will often give up. And that's a real shame. And particularly as there is sadly no cure for rosacea. Like there's no cure for acne. And I don't know if you've noticed in your sort of research about me, but I tend not to be terribly active on social media. But I found myself at the weekend reacting to someone who was marketing a product talking about curing acne. And anyone who leads patients to believe that there's a cure for an incurable condition, I feel duty bound to react quite firmly back towards that. And sadly, whether it's rosacea or acne, and of course, rosacea is actually acne rosacea. So it comes under the same larger umbrella. They're both challenging conditions. Both have differences, but there can be an overlap between the two.
So when you actually come to somebody with acne rosacea, because if you've got two things going on, you've got one set of treatments there to try and bring the inflammation down. You've got the other one there to sort of try and fight the acne and reduce inflammation. What takes priority?
Well, that comes out in the history with the patient. We are kind of lucky in that the acne proper and acne rosacea do divide themselves in large part because of the age of the patient. Because of course, acne is a young person's condition, and typically rosacea tends to become more problematic in the 30s and 40s. But there can be almost a seamless transition between the two. But it's a case of, we go back to our basics as doctors, and it's a case of we take a history, we find out what's troubling the patient, we then examine them, we then formulate what we refer to as a differential diagnosis, which may include, acne and acne rosacea. And we then have to, as with anything that we do, we need to consider, with a treatment, what can we win, what can we lose? And I spend all day, every day thinking, okay, I'm working on the basis that this patient has presented with this issue. I believe it to be this diagnosis. What can I do? And any particular treatment I might be considering, it's a case of saying, what is the chances that this is going to help? What could actually happen negatively in terms of that? And if you bring the patient with you on that journey and help them understand, then they're sort of forewarned, forearmed. They understand that it can be a journey because, of course, there's no cure. So it's a longitudinal process. And if you help them to understand that everyone's a little bit different, if they've got barrier disturbance with their skin function, then of course you want to repair that. A lot of what we're doing is seeking to reduce the inflammatory element of their problem. And then it all depends on what their primary issue is. If they have, pustules, then we want to be treating those. And often in that situation, we have topical treatments or we have antibiotics that we may recommend for a short spell. If someone has marked flushing and they present saying, well, I've got flushing and it's been getting worse over the years, and I've now got these dilated vessels, then for the most part, we're looking at energy-based devices to try to take those unnecessary vessels and close them. Because a lot of the time we are signaling to the body that something is unnecessary, it's surplus to requirements, and please get rid of it. So we're encouraging the body to facilitate the removal of unwanted vessels, or in the case of a rhinophyma, we're saying, we've got this thickened skin, we've got this enlargement of the glandular tissue in the lower part of the nose, and we're actually removing that tissue. So we're trying to, I guess, work in partnership with how the body works. It's difficult to fight against it because we then create problems. We obviously want to work in tandem with the patient so they know where we're going, as well as the respective merits and limitations of any given treatment. And I believe in honesty and openness with patients so they can understand and realize that I'm not going to promise them something that I can't deliver on. And in fact, if anything, I will tend to under-promise with the intention of over-delivering.
Which is always a good thing. Do we know why some people go on to develop a nose like others, that sort of that tissue starting to grow? Do we know what prompts that?
No, we don't.
Fair enough.
Some will say that there is a tendency within the family. We believe that there may be an androgen effect explaining why males are more common to suffer from this condition than females, but we don't fully understand what is going on.
If people start to notice that they've got that type of thing starting to happen, can you control it with topical treatments and sort of keep it under control, or do people just go on? How does this evolve, and what can you do in the early stages?
Well, it will ultimately depend where you live. And we know that for early phymatous change, the most effective treatment for that will be oral vitamin A prescription medication, Roaccutane effectively, or Accutane, depending on where you're living. And this is a treatment that's well known for treatment of severe cystic acne. And a lot of people who've suffered from severe acne will have been on Roaccutane or Accutane. And that will be the most effective treatment for the management of early phymatous change. The challenge is that in the UK, because of budgetary constraints, staffing issues, an element of willingness or lack thereof, I've not seen anyone who's had that treatment to try to prevent the development of rhinophyma. And
you should think that would be quite a cheap option, really, wouldn't you?
It should be, well, a cheap option compared to what, though?
Well, the psychological trauma and counselling that they'll have to put up with and pay for afterwards, I would have thought is one thing.
Well, it's interesting that you say that, because I was talking to someone yesterday, and they said, "Gosh, I wonder when you treat rhinophyma, given the dramatic impact that can have on someone's life, how much will that be benefiting society in terms of a functioning human being who doesn't have distress, psychological issues, withdrawal?" The reality is that, unfortunately, in our experience, these people just become hermits and they disappear. And
Mm.
so they don't appear to be much of a burden other than potentially on their wider family circle. Um, Patients like Alan, who had severe phymatous disease, and I've spoken to learned people across the Atlantic who said, "I've never seen rhinophyma as severe as this. They've just not seen it."
I
And
mean,
maybe
it
that's
almost looks from the photos that it was almost about to like occlude his breathing.
yes, yeah. And we've had numerous patients who will say, "Gosh, my breathing is so much better." Not even that they've been aware that there was a problem in the first place, because of course it is such a
Slow
gradual
development.
onset that people don't even know there's a problem. But we've had multiple patients sitting forward in the chair and going, "Wow, I can breathe." And of course, this sort of thing is dramatic. And if you purely presented to your GP with a breathing problem, you would be referred for consideration of surgery in the NHS. But when you present with what is perceived as a cosmetic problem, suddenly you get humming and hawing, and yeah, we can't really do anything. Or we've had multiple patients saying, "Yeah, maybe we could do something, but it's very risky, and you'll have a prolonged recovery, and you may have severe bleeding, and you may have scarring." And if you tie that up with a bow, effectively they're trying to talk the patient out of seeking any intervention. And that seems like a shame, because we have solutions that, yes, they have downtime, but we have patients like Alan who no more than 3 weeks later they are outside interacting with the human race again.
Yeah.
And that is, yes, it's quite a lot, but it's something that for the majority of our patients, we do it once. It seems
Well,
to
I mean, I
have,
guess if you think about it, people go and have a severe peel or a big ablative laser treatment. They're going to be down for 3 weeks later. While you're talking, let me see if I can actually share the screen without destroying our entire
okay.
thing. Share screen, 2 monitors. Where is that? That's there, and then we can see the very lovely Alan. And here he is. So yes, basically this is can you see the screen?
Yes, I can. Thank you. Yes.
Yep, excellent. So basically, yeah, talk us basically through when he came in. What did you think and what did you do while I flick through these?
Well, it's very interesting, because he came in with his head down. He was, embarrassed to be in a place of care where he was coming to see if we could, provide some assistance. He was obviously concerned primarily with the center of his face, which was very much out of sync with the rest of him. And, he will have, if you look closely enough, as I unfortunately always do, there's a coarseness to the rest of the skin. As with anyone else of a similar age group, there will be lines, there'll be wrinkles. There's graying, there's a bit of recession, like some of the rest of us may have. But his overwhelming area of concern was this dramatic enlargement of the lower section of his nose, with extra elements hanging off. I mean, this is markedly severe rhinophyma. And if you look at how rhinophyma is classified, something 90% less than this would still be classified as severe. So it's very much a case of considering, how do we reveal the underlying nose? And the way I approach this is almost a sculpting exercise to try to work out, as I mentioned earlier on, what intervention can we do that, on the balance of probabilities, is going to lead Alan to having a positive outcome? How can we marshal him into a better situation while avoiding a negative situation? And of course, we have to consider risks of infection. We have to consider risks of scarring. this goes without saying because we are creating a wound. And when you look at how a patient looks in the few days after this, as Alan has quite famously reported, he felt like he'd been, as we say in Scotland, duking for chips.
Which means?
Are you familiar with, so at Halloween, children will duke for apples. So, you know, certainly when I grew up in Ireland, you know, we would be ducking for apples at Halloween. So he felt like he was ducking for chips because it was as though he'd put his nose in the deep fat fryer. And that was a pretty fair representation of how he actually looked for more than a week. So potentially distressing, but of course, if the patient is given an understanding of the journey that they're going to go through, going from his starting point through to the end point, then they can understand that. And if we build trust so that the patient knows that we're there, and any patient who's getting this procedure will be in regular direct communication with myself to make sure that they're comfortable, to make sure that they are healing in a manner that I anticipate that they will, so that we can intervene early if there is any challenges. And Alan actually is the only patient that we've had so far who required 2 treatments. And all
I mean, the fact that only 2 is a miracle in itself, really.
Yeah, absolutely. But it's one of these things, there are different factors during a procedure that may prevent us from being able to get completion or reaching the end point that we're looking for. And so even much milder but still severe rhinophyma that we see, we always say that it may take more than 1 treatment. But Alan is the only patient who's required 2 treatments so far. He is also the only patient that we've had who actually developed a bit of an infection during the second treatment that he had done. But none of these things were an issue because of the regular contact. And he knew that we were there. He knew that we were looking after him. And so he was comfortable through that process.
Yeah. With the, so you did the first one. What sort of period of time for recovery was there and between the second one? So from beginning to end to what he's got now, how long did that actually take?
From memory, I think it was about 3 months.
All right, that's not bad. And in terms of pain and discomfort, you mentioned that you got an infection the second time around, but the treatment itself, I mean, you took off an awful lot of skin there. Is it, how painful is it if people are thinking about doing this?
So there is, as with anything else, there's a variability to how the anesthetic takes, but most of our patients feel very little, if anything. We do a series of injections to numb the area of treatment, and it's our anticipation that patients will feel minimal discomfort. And
afterwards? I mean, I've had a laser treatment myself, and I remember feeling very hot afterwards.
Yeah, the nose does, in keeping with what Alan said, you would feel like you were duking for chips. So it feels very hot afterwards. In essence, we've created a burn that needs to be cared for afterwards. And but it's something that we're always very interested in the aftermath, to establish what does the patient need. So I'm always inquiring, do you need stronger painkillers? Because I'm very open to the provision of whatever the patient requires. And it always surprises me that simple over-the-counter painkillers seem to be perfectly adequate.
Well, that's good. The in terms then of afterwards, once he sort of started to recover and things are falling down, I mean, from now on, what does he have to do to keep that from coming back? Are there topical sort of skincare treatments that he could use just as somebody like me with rosacea would use?
Well, generally speaking, because we've had such a dramatic remodeling of that nasal tissue, what appears to happen is that we develop a protective lid on top of it, because that new skin has a lot of new collagen. So if you imagine, it's almost like a shell on a nut, and we've not seen any regrowth. And other providers of similar treatments, they have a very low risk of recurrence. And we believe that's because of the intense remodeling of that nasal skin, that it provides resistance to the progression of this. Now, obviously, we're receptive to that, and we always say to patients, we can't provide guarantees about that, but we do know, and we're open and honest about the fact that there seems to be a very low rate of recurrence, and that is the hypothesis that we have, is that following the laser, the new skin resists that development of enlargement and thickening of the tissue that was previously present.
Interesting. Is the I guess because this is quite new, I suppose you'll be watching Alan over the next few years like a hawk, just to see how he progresses.
Yeah, and it's funny because it seems to be a small world. We had another patient in yesterday who said, "Oh yes, I know, I can't actually remember the family connection, but he was familiar with Alan and knows the family." And as I say, in Scotland, we do seem to have a lot of rosacea, so maybe we have more rhinophyma than other parts of the UK and beyond. But yeah, we're going to be a network. We leave it that we're very responsive, very keen to know how people are getting on, and we'll obviously guide them into the future.
Oh, I seem to have dropped a bit of connection there. I missed your last couple of words. So what did you say?
Oh. I mean, I was really just saying that we're going to continue to monitor them, and we are keen to be available and guide them depending on how things happen for each individual case.
For people who are sort of at the beginning of the development of that type of tissue, what sort of tissue changes should they be keeping an eye out for? And then would having something like this very early on save an awful lot of pain later on down the track?
It's difficult to tell, because obviously with any given intervention, we're weighing the wins versus the losses. And if you have a very mild rosacea, then you have less to gain and more to lose by having an intervention. What patients will typically watch out for is enlarged pores, but some people have large pores anyway. Patients with oily skin will be aware of their T-zone, will be aware of excess oil, shininess, enlarged pores. So that can be a sort of non-specific sign. It's when they progress to having thickening of the skin, which would be the sort of middle category for development of rhinophyma. Then they'll get an idea. The skin is becoming thicker. We always advocate looking at old photos, and with any patient that we see, we say, can we have a photo from years ago, before this all happened? And it helps us to understand what the nose looked like before. But ultimately it's when they've got thickened skin. That's going to be the situation where considering something like the Roaccutane would be worth considering. But it all depends on where the patient lives, what their access to care is, whether they can gain access to that. It will typically be more when the nose starts to become lumpy and bumpy, that then laser can be beneficial. And we've had some patients who've had much milder forms of rosacea, phymatous rosacea, and we will, after discussion, intervene. But we're very clear that if you've got a mild deformity, then you've got less to gain, and there's arguably more to lose. And we very much focus on making sure that we avoid those losses. So conservative treatment as much as we possibly can is the approach that we take.
Absolutely, which makes good sense. You mentioned a photo before to see what his nose was like before a patient, because with that amount of tissue, when you're taking it off, how do you know when you've got back to what would be normal tissue? I mean, can you see the difference as the tissue changes as you go down, or how do you know where you've got to? I've got a large monitor, and when I'm lasering, I will often make reference to that screen with the photograph zoomed in, so I can tell what the nose used to look like. But we can also tell when we're removing the tissue, it's very glandular, and there's a specific sign called a gopher sign that we see. And basically,
it's like a gopher popping up, and it's gooey, mucousy stuff that appears out of the pores. And when that is no longer happening, we then tread with care.
Mhm.
Because obviously if we remove too much tissue, then we're going to get scarring. And you could argue that, and I'm sure Alan would have been of the opinion that he would have much rather had some scarring than the nose he started with. And this is where what I mean with wins and losses, because I almost feel like it would have been hard not to move Alan in the right direction. Whereas if you've got very, very minor rhinophyma, it would be easier to have a negative outcome.
Mm.
So while Alan's was very difficult, in some ways, it was easy.
Yeah. Brilliant. Is there anything else that we sort of need to cover? Because I mean, looking at him, you can tell that he's obviously a very, very happy man. That little straight-on photo there, he's looking, he literally does look like the cat that swallowed the canary. He's obviously in a much better place. Is there anything, words of wisdom that you would give to people who are feeling like him, who might be umming and ahhing about whether or not they should get something like this done?
I always work on the basis that we're there to empower patients with choice. And I can absolutely understand that if you're affected by this condition, there's a natural instinct to recoil, withdraw, not do anything. And in our experience, it's more often than not someone else, a loved one, who not necessarily drags them to the appointment, but gives them a nudge, prompts them, encourages them, and then they come in, they find the information. And it's all about having choice, and it's empowering yourself with the information to make the choice that's right for you. And, we'll see patients who might be on complex medication where other risks or issues can arise. And, for example, when we have rhinophyma, it can be very, very vascular. Often there's very large vessels in the midst of this tissue. And of course, if we're removing that tissue, it can bleed a lot. And if someone is taking medication that makes them more likely to bleed, then that's something that we need to consider and we need to manage from a risk point of view. Because no one's going to thank us for phoning an ambulance and sending them up to the hospital because they're bleeding excessively. So we're always considering the bigger picture. Everything is from a holistic standpoint, and considering can we help, because that's what we want to do. And we will always be honest. And I am very happy to say to patients, either I think it's much too mild, or I think your risks are too high. I will provide them with the facts, because it's my duty to keep them out of harm's way. And I will not lead them into a situation that I don't think they can get back out of. And I'll just be honest with them about that. And sometimes the patient will get the information they need. They will go off and have a think about it. They may then seek further information or advice. And that's perfectly fine, because it can be a journey for them to reach the point at which they make the decision, which may be, okay, I'm really happy that I found out that there are options. Maybe I'll consider that at some point in the future. That then gives the patient a feeling of more control over what's going on, rather than feeling that they have no options, that they're a nuisance, that they're surplus to requirements, that they're no longer a member of the human race. Things that we've been told by numerous patients. And, I think that helps us to, discharge our duties, but also feel really happy that we are helping people who have previously not been able to find help.
Yeah, absolutely. And I mean, you're a GP by background. You've done extra study in cosmetic dermatology. If people are looking for somebody to get something like this done with, what sort of qualifications and experience should they be looking for? Because as we know, beauticians can buy lasers. So you'd be wanting to know you were in really safe hands if you were getting this done.
We have heard of other providers who are actually, well qualified, but it's a minefield, because you have to be qualified. You have to have a very sound understanding of the principles of the use of laser in skin. And you also have to have the correct devices, because if you've got the wrong device, then it doesn't matter who you are or what your background is, what your understanding is, you have limited yourself by using the wrong tool. And you speak to any surgeon anywhere, they will insist on having the right tools for the job. And anyone who is a crafts person, who is wanting to provide optimal results, they have to be using the right tools. And we have the best tools. There are no better tools available that we could be using. And if you're not immersed in, laser dermatology, then you won't be expected to know that. You will be unconsciously incompetent, in essence, and you will unfortunately then lead the patient into a situation where they are much less likely to get a positive outcome or a safe outcome. So it's a minefield.
Yeah, I can imagine. When you first did this, did you take a deep breath of fear yourself, thinking, "Oh my God, what am I entering into?" Yeah.
Yeah. And it's, there's always going to be a case of taking a step. When you're trying to do the right thing, there's going to be that from time to time, but you do that with the right background and the right principles in providing care. And if you're not familiar with using this kind of technology specific to treating skin, then you couldn't really be expected to be in a position to get a positive outcome. But it is a bit of a minefield for patients, and I'm genuinely wanting to help people with this condition. I'm very happy to offer guidance. As I say, I do politely decline to treat patients who I believe is not in their best interest to have treatment. And that can be typically for medical reasons, but it could be for psychological reasons as well. And that's what I meant earlier about that holistic approach. And we have to consider our duty and how we're caring for people, and ultimately what that individual needs. And if someone needs therapy, then we will refer them for therapy. So, yeah, and I think that that's a very important point, because, in this modern world where, apart from treatment of rhinophyma, we're used to things being accessible. We're used to having things on demand. This is a very considered option, and it's something we would only offer if we believe it's in the best interest of an index patient. And that would be following a consultation. We sometimes have patients saying, "Oh, but I don't want a consultation," because of course, if we're seeing someone, there's a consultation fee. But we stress to patients that it's all about assessment, and just because you have a consultation doesn't mean you're going to have treatment, or maybe not this year or next year or the year after, because we're simply wanting to provide options so the patient can make the best choice.
Yeah, absolutely. Speaking of consultations and consultation fees, just generally in terms of a ballpark cost on this, if somebody was considering it, how much would they be out of pocket?
Sorry, I'm losing you a little bit there.
I was just wondering, how much would people be out of pocket if they were considering?
Okay. Yeah, so we typically charge a consultation fee of £100, and then treatment for rhinophyma is £3,000. If there was a need for additional treatment, then there may be a surcharge on top of that. That's unlikely. And as I say, Alan is the only patient that we've had who has required a secondary treatment.
Yeah, and I would imagine from Alan's point of view, he's probably thinking that's money well spent, because that is like, we use the term life-changing considerably, and here comes another police this time. We use the term life-changing quite frequently, but that really is a life-changing treatment for him. Amazing.
Yeah, and I mean, we've had numerous other patients who, they've given up their job, it's had dramatic impact on their life, because, as you mentioned earlier, people feel scrutinized but also judged. And, we had another patient who's a photographer who, felt that everyone was just drawn to his nose, and he just became so embarrassed that he actually stopped working. So yeah, it's a big issue. I think it's made worse by the fact that it really is the center of the face. So it's very hard not to see someone's nose. If, you can get phymatous disease affecting the ears, for example. It's not something that we've got any real experience with, but, for ladies like yourself, if you had that, your hair's going to cover it. I might struggle a little bit myself, but, it's less central than right in the middle of your face.
Yeah, absolutely. Very true. Well, brilliant. Look, thank you for that. Is there anything else you'd like to add, or do you think we've covered it all?
I think that's pretty much everything. When it comes down to the nuts and bolts of it, it's actually quite straightforward. It's just about, getting the diagnosis correct. It's about knowing how to do it. It's about having the right tools. It's about developing an early relationship with the patient so that they know that you're their advocate and you're going to always err on the side of caution to optimize their chances of getting the best result they can possibly get. And for me, that's quite simple.
Brilliant. All right, Cormac Convery, where do we find you? You're at the Ever Clinic in Glasgow, Ever Clinic on Instagram, and the same on Facebook and everywhere else. If people want to get in touch.
Yes, we're certainly on Google, where most people look nowadays. Other websites and other search engines will certainly weed us out as well. But yeah, I also have a significant interest in management of complications, and this is one of the things that I've been trying to advocate. You mentioned about how lots of people can just purchase a laser, and one of my key aims is to try to ensure that patients aren't left adrift. And we do find patients from time to time who've had a treatment who are just sort of cast aside when things go wrong. And I'm one of the original group that set up a complications management group that's UK and internationally available to help patients. So I can be found through there as well.
Oh, brilliant. That's really important, actually. I'm chairing a discussion at a conference in February. It's a menopause in aesthetics conference, and it's going to be covering vaginal rejuvenation and things like that. And basically, I can go out tomorrow. For $8,000, I can get from China a very lovely CO2 fractional laser with a handpiece for doing vaginal rejuvenation. They'll send me a beautician to train me. And so I said, can I, my hairdresser, she'd like to have one as well. She's thinking of putting a clinic in her hairdressing salon. She said, no problem. If you buy two, I'll throw in a hydrofacial as well. And I thought, there's my future. Fifi's Fabulous Fannies coming to a hairdresser's near you.
Well, I did notice that conference, and there's a couple of my colleagues and friends who are involved in that. Charlotte and Shirin, I believe, are talking at that. So
they are.
So yeah, I'm sure that will be expertly led. It's not an area that I've got so much knowledge or experience with, but yeah, it's a growth area. Sadly, not always in the right direction if these machines are being sold to the wrong people, but I'm sure that we'll be starting to see complications coming through when they're provided by those wrong patients. But I hope you have a good time there. And yeah, if you're in need of any guidance, Sharon's a member of CMAC, which is my complications group. So yeah, we can be found helping and doing good in other areas as well.
Absolutely. Excellent. Well, look, thank you so much. We will leave it there, and hopefully we'll speak again in the future. All right. Take care.
Okay. Thank you very much, Fiona.
Thanks. Bye.
Okay. Bye-bye.